Welcome to this RCPE podcast of COVID Conversations. My name's Dr Rachel Sutherland. I'm on the Trainees and Members Committee at the college, and I'm an ST7 in Acute, General and Stroke Medicine. Today I am talking with Professor Mark Strachan, who is a consultant endocrinologist and diabetologist at the Western General Hospital in Edinburgh. Professor Strachan is also a researcher and works at the University of Edinburgh. The reason that I have been asked to do this podcast with Professor Strachan today is because there's lots of questions about diabetes in the COVID patient. And I'd like to begin with the first question, which has come from a number of colleagues, which is to understand a bit better why diabetics have been put in the at-risk group for COVID-19 disease.
So we've known for many years, Rachel, that people with diabetes are at an increased risk of infection in its broadest sense. And that probably relates to the effects of hyperglycemia on the immune system. We know that hyperglycemia can affect the function of neutrophils and so increase the risk of bacterial infection. It also probably has an impact on other aspects of the immune system around B and T cell function. What we don't know is whether there are differences within the broad spectrum of people with diabetes. So are people with type 1 diabetes at the same risk as people with type 2 diabetes? And does the level of glycemic control that an individual has modify that risk? Intuitively, you would think that somebody who has got extremely well controlled type 1 diabetes would be at much lesser risk from COVID than an older person with type 2 diabetes with all the comorbidities that often go with type 2 diabetes, and who has got very poor glycemic control. That is intuitively what you would imagine. But the reality is we do not have robust data at the moment to know that for certain. So that's why the government has put all people with diabetes in the at-risk group for COVID infection.
Do you think, Prof, given this focus on obesity, that we should perhaps be advising people to complete some weight reduction at this time? Or do you think that's just a bit of a step too far from where the evidence base we've got at this point in time?
Well, more overweight people are more likely to have the other comorbidities that we know put people in a high-risk group. So diabetes, hypertension, and obviously we know about this potential association with ACE inhibitors and ARBs and an increased risk, although that again is not by any means certain. So I think there are many potential reasons why obesity would be a factor, but I would imagine that comorbidity element would be a major player in that.
I guess the reality is that this is about lots of marginal gains. It's a bit of this, a bit of that, and overall we're just wanting to improve people's general health, and that's kind of all for the good. That's the message we as physicians can give, I guess.
It's more, I suppose, a public health message, I would think. There's no doubt that losing weight is beneficial, not just from a COVID point of view, but from many other aspects. And of course, many people are going to have a lot more time on their hands now. And so bringing in an element of daily physical activity, of watching what you're eating, and weight loss if you're overweight can, in my mind, only be a positive thing. And if you have particularly type 2 diabetes, the weight loss will improve glycemic control. And if that level of glycemic control is relevant in terms of risk of infection, then again, intuitively, that should be a beneficial thing.
I guess from a pragmatic perspective, the other thing that I've seen when working within the metabolic unit with yourselves is some of your colleagues have promoted the MyFitnessPal app, which is a free app where you can monitor your calorific intake as well as your energy expenditure in terms of what exercise you are completing. And that's a really good way to track your intake and your output and to try and improve your weight or your general fitness. So perhaps that's a tool for people to use.
Yeah, absolutely, totally.
So my next question really is leading into more of the secondary care setting. And one of my colleagues has raised a question about monitoring of diabetics that come in with COVID disease. And whilst I was working within your department, there was a large number of diabetics with flash monitoring devices such as the Libre View. And the question was about when you get people who are particularly pyrexial, can we continue to use that form of monitoring in the inpatient setting, or should we be moving to capillary glucose testing? And I just wanted your advice and opinion on that.
Yeah, that's a good question. I think the simple answer to that is yes. I mean, you might imagine if somebody is very pyrexial, is very sweaty, it might make it more difficult for the sticky adhesive tape that is part of the Freestyle Libre to adhere to the skin. But actually, in practice, people with type 1 diabetes who are very physically active anyway will be very sweaty at time points. And actually, that doesn't seem to be a major issue. So I don't see any barrier to using flash glucose monitoring in a pyrexial patient. I can actually see a lot of advantages to using it. There's no doubt that if you've got somebody, for example, on intravenous insulin in a high dependency area, having nursing staff going and having to do hourly blood glucose monitoring, that is exposing them to additional risk over and above what would be the case for a non-diabetic person. And the beauty of flash glucose monitoring is that literally you can wave the reader across the arm of the patient and get a reading. So actually, in theory, would reduce the physical contact time with patients. And it is actually something that we are thinking about in our hospital, whether we should be deploying this more widely in our critical care areas for COVID-infected people with diabetes.
That's absolutely fascinating, and I think incredibly helpful for a lot of people, on the front line of this disease, dealing with these patients. So I think that would be really helpful to take forwards. The next question that was raised by somebody else was about interpreting a capillary glucose during a significant pyrexia. So in COVID, we're seeing a lot of patients with significant pyrexias, sort of above 38 up to sort of 40. And I wanted a little bit of guidance on how we interpret the capillary glucose in the context of significant pyrexia. And I guess this is not just a question about COVID, but about infection in general.
Yeah, wow. That's a really good question, and I really don't know the answer to that. Intuitively, you would imagine that a spike in temperature will be associated with a rise in glucose, because you're getting all these counter-regulatory hormones released that antagonize insulin. But I suppose at the end of the day, you got to go on the glucose reading that you have before you. And if somebody's sitting with a blood glucose of 24, whether or not they've got a pyrexia, that is their glucose level. And I suspect whilst the glucose may be pushed up by the pyrexia, it probably won't come down necessarily that quickly as if the pyrexia declines, for example, if they've been given an antipyretic. So I think at the end of the day, you've just got to treat the glucose levels and not necessarily overthink or overcomplicate things. And I am keen on one level that we do minimise blood testing in one sense in people with diabetes who are in the wards if they don't need it. So because again, that is going to increase staff contact time with infected patients. So I'm not a massive fan of the idea of doing multiple repeat tests, and I would just be pragmatic and treat the sugar that's in front of you.
So that was a really helpful and pragmatic solution and some guidance there, Prof. So thank you so much for that. This leads on to sort of, the fact that when now in secondary care, we're probably going to come into contact with quite a significant proportion of the population with unknown multimorbidities. And my next question is really about newly diagnosed diabetics or people with uncontrolled hyperglycemia who are coming in during this COVID pandemic. And I guess it would just be some, again, common sense, pragmatic guidance in how we approach the newly diagnosed diabetic or somebody with hyperglycemia during acute illness. And if you could just give us a bit of a very rough guide, it would be very gratefully received.
Yeah, I mean, you're right. There is, at the end of the day, if they're hyperglycemic, they're whether or not they've got COVID or not, in a sense, doesn't make a huge difference. Other than if they are very hyperglycemic, then there may be some merit in trying to normalise blood sugar levels, again, just around immune function. I say that without any scrap of evidence to support that. We just don't have the detail that improving glycemic control in acutely unwell people with COVID makes a difference in the long term. But again, intuitively, you would think it might. So broadly speaking, the approach is going to be as it would in a non-COVID person. You just want to make sure that the person is not ketonemic or ketonuric, that they're not acidotic or ketoacidotic, because those individuals will almost certainly, in the context of COVID, need insulin therapy, either subcutaneously or intravenously. There will be a limit on the type of anti-diabetic agent that can be used in more well people, and so agents like the new SGLT2 inhibitors, so that's drugs like empagliflozin or dapagliflozin, are associated with volume depletion. You can get a rare form of euglycemic ketoacidosis with them. These are not drugs that you'd want to be initiating in an acutely unwell individual. Metformin is obviously an issue if you've got acute kidney impairment. I suspect that we'll be going back on more tried and trusted therapies such as sulfonylureas, agents like gliclazide and glipizide, and insulin to manage hyperglycemia in COVID-affected individuals. I
think that was a really helpful synopsis and an overview, Prof. So thanks for that. And I think it will be helpful for staff returning to frontline medicine and redeployed staff, redistributed staff from other areas. So thanks so much for that. And I guess this moves on nicely. You touched on metformin during that discussion, and I think I want to talk about the diabetic coming in with COVID now and specific things we need to think about doing. And I guess I'd like some guidance on diabetes medications and specifically metformin. So could you just give me your steer on how you approach the newly type 2 diabetic patient who comes in on metformin who's acutely unwell with COVID?
Yeah, so in essence, the metformin should be discontinued. There is an association between metformin and lactic acidosis. It is debatable whether or not metformin is a precipitant or whether it's almost like a cofactor in that. But as a general rule, if somebody is acutely unwell, particularly if they're hypoxic and if they've got acute kidney injury, then it's better that metformin is discontinued. And I say that because there are always alternative agents, such as sulfonylureas, such as insulin that can be used. And so there's no point in adding to the burden on a patient. We would generally recommend stopping metformin in somebody who is acutely unwell. The same would go for the SGLT2 class of drugs. Again, that's the dapagliflozin, empagliflozin, canagliflozin group. I would have a very low threshold for discontinuing this treatment in an acutely unwell individual.
And I think it's really important for us to be mindful that the majority of these patients are actually going to recover. And so taking that guidance about cessation forwards, could you give us a steer for, our primary care physicians, hopefully when these patients are discharged, when we should be looking at reintroducing these medications?
Yeah, I mean, again, just being very pragmatic, once the individual is back eating and drinking again, normally they've got normal oxygen requirements, and their renal function is back to their baseline or near normal, then it's absolutely fine to restart these agents in that context, in that situation. And you're right, it's important that we don't want people with diabetes being discharged with very poor glycemic control, because that's not going to be doing them any favours in the medium to long term.
So I guess the next question that I want to move on to is about patients who are being treated for their diabetes with insulin whilst they're in the inpatient setting, specifically those on basal bolus regimes. And while they're in the acute phase of their disease, I just wonder if you could give us a common sense and pragmatic approach about how we should be dealing with, known diabetic patients with hyperglycemia during an acute illness who are on insulin.
So what I would say in the first instance, you've got to be clear of what the targets are that you are aiming for. It's very important in people who are on insulin and sulfonylureas that people are not having episodes of hypoglycemia. There's a lot of circumstantial evidence that hypoglycemia in an inpatient context is harmful to the individual, harmful in terms of potential cardiovascular events, harmful in terms of mortality. So avoidance of hypoglycemia is very important, but as we've discussed, by the same token, you do not want people on ward areas with extremes of hyperglycemia. So broadly speaking, a glucose target of between 6 to 12 millimoles per litre is a good target for the average individual, particularly the older individual with type 2 diabetes. Some individuals with type 1 diabetes will not be comfortable with a target of 6 to 12, and they will want themselves to have more stringent targets. And that is one thing that's important to remember, that particularly people with type 1 diabetes are very used to managing their diabetes. So providing they're well enough to do so, then it is important to take into account the views and wishes of the individual. So the first thing to say is be clear about the target. So 6 to 12 for most people is fine. And I think it's very helpful to write on the glucose monitoring sheet or the insulin prescribing sheet what the target is, so that people are aware of it.
I think that's something we often overlook, isn't it? That defining the target and making sure that's clear for everybody in the allied health professional team.
Yeah. Absolutely, and and particularly in older, frail people who are not able to articulate that they're recognise that they're going high. Target of around 6 to 12 becomes even more important. What you're not wanting to be doing is hammering down blood sugar levels, trying to aim for levels of 4 or 4.5 on very busy ward areas, because if you do that, you will increase hypoglycemia levels on the unit.
That's a really important safety thing for folk to be aware of when wards are getting busy and there's pressure of time. That especially for those patients, hypoglycemia is really the risk to them, rather than sugars that are running between 10 and 12, for example.
Absolutely, that's exactly right. That we just got to remember that there is a happy medium. Yes, we don't like to see people with very high blood sugars, and as we said before, that may have negative effects on the immune system. But actually, hypoglycemia is a big issue, and is one that on very busy ward areas, very easy for an older patient come hypoglycemic and it just not be recognised by individual themselves, or indeed the staff on the ward.
And I guess when I wrote to you, one of the things I really wanted to touch on were the pump patients in particular, and perhaps I only speak for myself here, but as a general physician, I think a lot of the pump patients have a really good knowledge of their diabetes and are really in tune with their pump, and the reality is they know a lot more about their pump than I do. And I, know that a lot of my colleagues are in a similar boat to me with that and are quite twitchy about pump patients admitted via the general take. And we generally get the diabetes team involved with such patients quite early on. And I wondered if you could give us a bit of a steer on how we should be approaching these pump patients, the few that are out there that come in during the COVID pandemic, and what your general pointers would be about their management.
Yeah, so you're absolutely right. People who are on pumps, by definition, have or should have a greater level of understanding of their diabetes and of their insulin therapy. At the time they were started on a pump, information about what to do with their pump, with their insulin, with monitoring for ketones when they become unwell, and that those sick day rule guidelines are reinforced at their outpatient clinic appointments. So the person coming in who's on a pump, if they're well enough, should be able to manage things, and actually they will almost certainly manage it better than medical staff on the wards. With no disrespect to the staff on the wards, it's just the reality of the situation. But obviously, if the person is obtunded and they're just not physically or mentally in a state that they're able to manage their diabetes, and actually in that situation, it's better that pump is switched off, the giving set is removed from the patient, and that they're managed with either multiple daily subcutaneous injections of insulin, or if they're extremely unwell, with intravenous insulin. And absolutely, that's the sort of thing that the diabetes teams in hospitals should be able to advise and assist with. But ultimately, if the individual with diabetes is not able to manage their pump themselves, then it will have to be switched off and it will have to be disconnected.
And I think I cut you off a little bit earlier when you were starting to talk about something in relation to the management of patients with basal bolus insulin. And I wonder if this is a point where it dovetails nicely back to you being able to make your point about that.
So, I mean, really the issue there, and you alluded to it, Rachel, is that you want to be proactive in the management of an individual's diabetes rather than reactive. So the temptation always is, somebody's got a blood sugar of 18, give them a little bit of Novorapid to bring down their sugar level. But actually the better thing is that we should proactively looking at their charts, seeing what the pattern has been over the previous 2 days, and prescribing an amount of insulin that is appropriate for that. Obviously, you have to take in the circumstances of the individual. Are they eating and drinking? Are they is their condition deteriorating? Is it getting better? Because all these things will affect the glucose levels and the insulin requirement that person. It's very difficult to give precise instructions on what to do with any individual, because the variables are so enormous. But again, it's the sort of thing that diabetes teams should be able to assist with and give advice over the telephone about if people are uncertain.
I'm glad that we captured that last point you were making, Prof. That's incredibly helpful. And I guess the point to all this is there's always in most hospitals I've worked a helpful diabetologist on the end of the phone, always willing and able to give you advice. The next question I have actually moves quite nicely on from there, which is about staff members with diabetes. And, of course, trusts will have their own guidance about at-risk staff members, but I wondered if, from a diabetologist perspective, you could give us your steer on what staff members with diabetes should be doing during this COVID pandemic.
Yeah, so this is difficult because for doctors and nurses and other healthcare professionals who've got diabetes, there's an inherent conflict there. That there is the conflict that you want to be doing something, you want to be making a contribution, you don't want to be seen to be pulling back, but on the other hand, you've got the potential impact on your own health. I think for individuals who have got type 1 diabetes, whose diabetes is very well controlled, then I think, as I said at the beginning of the podcast, think the increased risks, are almost certainly very small. The advice that I would give is that people with the type 1 diabetes, like other high-risk conditions, should not be directly working with people with COVID infection or who have suspected COVID infection. That would be my advice and recommendation. I think that's advice and recommendation that's generally out there. So they should be working in areas where there are not known to be COVID patients. Now, you and I both know that there will be ward areas that are not designated COVID areas, where, of course, there will be people brewing the infection, or where it's unrecognised. And but I think that is a pragmatic balance between our inherent desire of making a contribution, and of course, and the need for us all to be making a contribution, but on the other hand, protecting the well-being of our staff.
And I've been really interested to observe, we've managed an incredible change in our practice in an incredibly short amount of time. And actually, there are so many ways that we can work. We're really exploring, our digital mechanisms, people working remotely. And I think it's more than possible that these people are able to be redeployed to give a contribution without putting them at risk.
Absolutely.
And I think, that we're seeing that on a daily basis, I think.
Yeah, absolutely. Completely agree.
So I know that in Scotland we're incredibly privileged, and there's a lot of work gone into the Sky Diabetes platform and other spin-off projects such as My Diabetes My Way that's come out of that. So I know that there will be ongoing research projects that are starting up, particularly about the diabetic patient and COVID. I know that you're embedded in the university and research sector, and I wondered if you could just give us a steer on if you're aware of any research projects that are currently being undertaken regarding the diabetic COVID population.
So most of the research that's being done is epidemiological in nature, and it is obviously coming from countries where they've had the largest number of cases thus far. And obviously a lot of that has focused around the comorbidities that are associated with increased susceptibility to COVID and increased morbidity and mortality. I think we'll be very well placed in Scotland with our record linkage between Sky Diabetes and inpatient data is to answer questions such as, what is the association between level of glycemic control and susceptibility to COVID and outcomes from COVID? Are people with poorer glycemic control at higher risk than people with good glycemic control? Are people with good glycemic control at increased risk at all? And that's something that we will be very well placed to look at. The problem is we will have to wait until the crisis is over before really we can be addressing those sort of questions in order to get the numbers. But we will be placed very well in Scotland to look at these sort of issues.
I guess my question about it is the advice about the Leave Review, because I've obviously worked in England and moved up to Scotland and obviously worked within the metabolic unit, your metabolic unit, and there's a lot more uptake up here on the Leave Reviews. And I think that would also be a really important outcome to look at, using the Leave Review during these situations, because I think that isn't standardised practice. And something that, as general medics, we're sort of starting to get more used to is using that, the swipe stuff. So I think that'd be a really interesting thing, going forward for acutely unwell patients with the Libras.
Well, it's interesting. I think that, as you've alluded to, Rachel, this whole crisis, this emergency is forcing us to work in ways that we've never thought about doing or have not been able to do up till now. And, to me, it's very clear that, within, 5 years or maybe even sooner, in the normal run of events, the flash glucose monitoring system would come. I could see that becoming the standard way that people with diabetes are monitored in a ward environment. Why would you do a painful and messy finger prick on patients and do something that's only giving you a tiny little snapshot of what's happening to their blood sugar levels across a 24-hour period? And of course, so one of the things that COVID might accelerate is the use of technologies like flash glucose monitoring in inpatient environment. Yeah, it'd be interesting to see if that sort of thing does happen in the months to come.
And I just want to extend my thanks for you taking part in this podcast today. I think it's been really helpful to cover those areas. And I guess I just want to wrap up by pointing towards any resources that you think if people would like to do some more reading. I personally found the Edinburgh Diabetes and Endocrinology resource page. It has a tab link down for professionals, and that's got lots of really excellent how-to guides on there that I've found helpful in my clinical practice. So that were the things that you would point us to. Another podcast, perhaps, on diabetes that you would advise for the general physician.
Well, the other resource that we encourage patients to use, but actually there's lots of stuff on it, is the My Diabetes My Way website, and that's got lots of useful information on it. And Diabetes UK again have got a lot of information on their website for healthcare professionals.
So, Prof, I just really want to say thank you so much for taking the time and bringing us your expertise in this area. I think it's been a really informative podcast, and I think it'd be really helpful for the frontline staff going forward.
Yeah, totally. No problem at all.
As I mentioned, we're going to put the links to all of the resources that we mentioned alongside this podcast, and we look forward to making some more in the future. Hope you enjoyed listening, and take care out there.